Greetings of the day. We are going to discuss about nerve agents. Very exciting topic. So, during World War II, scientists in Germany discovered and manufactured three nerve agents classified as GA or known as tabun, GB sarin, GT soman. In 1952, the chemists in Great Britain and America manufactured the agent VX and GF. Although the preferred terminology for these chemicals is organic phosphorus compounds, they are still referred to as organophosphates in most publications. These agents were chosen as a chemical warfare agent over existing insecticide because they had greater CNS activity and higher lethality than many of the organophosphates and carbamates used for insect control. With the advent of the Cold War, organophosphate production accelerated with both the United States and the Soviet Union developing large stockpiles of these agents. Occasional accidents occurred, sickening soldiers handling these agents. And one chemical exposure of the VX in Skull Valley, Utah, killed 6,000 sheep. That is huge. The Kuala Lumpur airport assassination in 2007 of Kim Jong-nam was carried out using VX. In the 1980s, Iraq developed an extensive capability to manufacture and weaponize these agents and used both sarin and GF against both its own Kurdish people and Iranians with whom it was engaged in a prolonged border war. During the Syrian civil war in 2000, the nerve agents were confirmed to be used as well, with over 800 civilian casualties. Today, not only do many countries have capability of manufactures these or similar agents, but the terrorist groups have used them also. The Shinrikyo cult, sorry for mispronouncing, used sarin in two separate attacks, one in Matsumoto in 1984, which killed 7 people, and in large release in Tokyo subway a year later that killed 12 people and sickened 5,500 individuals. The organophosphate compounds inhibit several key enzymes by binding to them. They bind to acetylcholinesterase in two-stage process. First stage is reversible if the antidote paradoxical is given. The second stage aging process where the enzyme is made unavailable to be regenerated by the paradoxical. Acetylcholinesterase breaks down the neurotransmitter acetylcholine. With this enzyme inhibited, acetylcholine remains at its post-receptor sites, causing excessive cholinergic stimulation. With the parasympathetic nervous system, there are cholinergic receptors at the muscarinic sites such as tear glands, sweat glands, bronchial secretion glands, and sinoatrial and atrioventricular nodes of a heart. Overstimulation of these leads to the dumbbells syndrome, mnemonic for the following symptoms, that is defecation, urination, meiosis, bradycardia, bronchospasm, bronchoria, emesis, lacrimation, and salivation. The second location within the peripheral nervous system where cholinergic transmission is affected is the neuromuscular junction or nicotinic receptor. Excess cholinergic stimulation here causes progression from muscle fasciculation to profound muscle weakness to complete paralysis in a dose-dependent fashion. Early in the course of an exposure, there can also be paradoxical hypertension. So paradoxical hypertension and tachycardia, but these both subside as bradycardia from muscarinic receptor to predominates in the clinical presentation. The last location of the importance for the cholinergic stimulation is the brain, where excessive stimulation produces coma and seizure. Many organophosphates cross blood-brain barrier freely, and the nerve agents in particular have potent CNS effects. So these are active. So this is the reason why they are used in these warfares. The treatment strategy for nerve agents must counteract the cholinergic excess at all these 3 receptor sites. So atropine counteracts only the muscarinic. So atropine is for only muscarinic. Paradoxical counteracts the nicotinic effects. Benzodiazepine treat the seizures, which is penetrates the CNS. So the indication for each of these agents varies with the clinical manifestations. So for the patient with exposure in low concentration, such as vapor release, only eye findings may develop. Pinpoint pupils can be seen frequently with local pain and may be treated with anticholinergic drops, eye drops such as scopolamine or homoatropine 1 to 3 drops, or and if pulmonary symptoms are isolated to bronchospasm in the reactive airway disease prone patient, ipratropium bromide may be adequate, and administer IV atropine to anyone experiencing hypersalivation, bronchial secretions, and bradycardia. Large doses of atropine, sometimes as much as 20 milligrams, may be needed in these patients, and this has been reported typical in the injections but could be needed in liquid exposure to nerve agents. High doses of atropine were not needed in the lower concentration exposures that occurred in the Tokyo subway incident. Titrate atropine administration to clearing of the excess secretions, pupil size, and heart rate responses. Pupil size and heart rate response are very poor indicators of adequate atropinization in organophosphate exposure. Paradoxical reactivates the enzyme acetylcholinesterase at the neuromuscular junction, and it can reactivate the enzyme only if the aging process has not occurred. How rapidly an agent ages varies from agent to agent, and VX takes 24 hours, whereas soman takes only 5 to 8 minutes and to age and to create an irreversible bond. The recommended initial dose of paradoxical is 1 to 2 grams IV slowly over 20 to 30 minutes. In a large event with multiple casualties, half of this may be given to spread the antidote to the maximum number of patients. Many patients with neuromuscular weakness will eventually require intubation and mechanical ventilation, and succinylcholine choline should not be used if at all possible, because the same enzymes inhibited by the organophosphates metabolize it. And the onset of action of succinylcholine choline will be same, usually less than 90 seconds, but the duration of action of this drug will probably prolong due to several hours due to unavailability of the enzyme to metabolize the drug. And seizures, when they occur, may be refractory, and in combination with the diaphragmatic paralysis, it will lead to respiratory arrest. So we need to intubate these patients, and IV benzodiazepine should be used in these circumstances to treat the seizures, and phenytoin and fosphenytoin are not effective for the seizure control. So we need to use the other advanced newer anti-epileptics such as levetiracetam and other agents. And patients with minor symptoms such as eye findings only may be observed for 6 to 8 hours period and released if no further symptoms occur. Admit any patient who received paradoxical to an intensive care unit and give a continuous infusion of paradoxical at 500 milligrams per hour or intermittent bolus dosage of 1 to 2 grams every 6th hourly. Thank you very much for watching this video.